So we left off talking about acute decompensated heart failure. And the way I remember this is typically that the other types of heart failure, systolic in particular, is essentially compensated heart failure. And so here we're looking at decompensated. So all of the compensatory mechanisms that we introduced in the pathophys component essentially become attenuated or severely restricted in terms of their ability to increase low cardiac output. And so at some point the system just doesn't respond. And so there's no point in supplying drugs that inhibit the compensatory responses because those compensatory responses are being severely weakened over time. And so one of the treatment strategies to very low levels of cardiac output is to actually provide drugs that are known as positive inotropes. Okay, so remember we said beta blockers were negative inotropes. So these drugs work completely opposite of beta blockers. And so the thing that works completely opposite of beta blockers is something like norepinephrine or epinephrine. And so drugs like positive inotropes kind of act like the endogenous epinephrine and norepinephrine. Okay, positive inotropes increase the amount of calcium, which allows for an increased contractility. And so the way I kind of always thought about this is that before we were keeping, in systolic heart failure, we were keeping the heart in kind of a subdued resting state by employing negative inotropes, like beta blockers. At this point now, the heart is beyond the cast of healing. And at this point, it's an all or none type of thing. If cardiac output doesn't return to a kind of a minimum level, the patient is going to die. And so between this acute decompensated stage and death is possibly the intervention of employing a left ventricular assist device, heart transplant, surgery, some type of more dramatic intervention. So anyway, so these positive inotropes are going to increase the amount of calcium, and that's going to allow for sustained increased contractility. Okay, and so it's kind of like that that bolus of epinephrine that you get in terms of the flight or flight response. That huge bolus is not healthy for you, but it's going to give you enough of a kick to get you away from that saber-toothed tiger that's chasing you through the jungle. So digitalis is kind of the prototype positive inotrope. Mechanistically, it's defined as the sodium-potassium ATPase inhibitor, also known as a cardiac glycoside. And so this drug is actually extracted from a common garden perennial plant from Europe. Many people have this growing in their garden. You may recognize it. The rabbits, of course, don't eat it, which is why I have it in my garden. It's the only thing that they won't eat because they know it's quite toxic. So how does this work? So the mechanism of action is a little involved. Let's go through it step by step. Okay, so mechanistically, we're going to see an increase in intracellular sodium, and that's really going to stem from the accumulation of intracellular calcium at that sodium chloride exchange system. Okay, so in the heart, high amounts of calcium mean more calcium to be released by the sarcoplasmic reticulum, and that more calcium that's available can bind to troponin C, and that's going to increase contractility and therefore be a positive inotrope. Okay, so inhibition of that sodium-potassium ATPase, however, in smooth muscle causes depolarization, and that causes smooth muscle contraction and vasoconstriction. So there's two different mechanisms at hand over here. What about digitalis? Well, another name for it is digitoxin or digoxin. It has a narrow therapeutic index. That means that there's a very, very fine line between therapy and toxicity. And so for that reason, it needs monitoring. You can expect changes in potassium, magnesium, and calcium. And it also needs clinical experience. Somebody who's just out of medical school probably wouldn't be writing for digitalis their first year in the clinic, because when inappropriately prescribed or inappropriately administered, digitalis can actually precipitate arrhythmias, and those are dangerous. From a pharmacology standpoint, there's numerous drug-drug interactions, and the changes that occur in physiology can actually become toxic at some point. And so low potassium levels are associated with arrhythmias. The Wolff-Parkinson-White syndrome can also manifest itself, as well as AV block. And so, while digitalis may be clinically useful in the context of acute decompensated heart failure, it's really problematic in terms of maintaining patients on this for long periods of time because of all of these drug-drug interactions and its narrow therapeutic index. The clinical indications for digitalis, note that it's not really a first-line therapy for either of the following conditions. It has been used in the past for atrial fibrillation or atrial flutter, which can produce a rapid ventricular rate. Digitalis works because there's going to be direct suppression of the AV nodal conduction pathway, and several mechanisms can account for this. In the context of heart failure, we're really kind of looking at the stage C or the stage D AHA heart failure stages in adults. Here we're going to see an increased myocardial contractility in both adults and pediatric patients. And so, there are specific instances where digitalis will be useful, but it's not across the board in every stage of heart failure. That increased contractility is going to come from the inhibition of that sodium-potassium pump. All right, that increase in sodium promotes an increase in calcium, and that increase in calcium therefore allows a greater contractility of the ventricular muscle. Okay, so that's kind of an introduction to digitalis and where it fits in the paradigm of heart failure. It wouldn't be a first-line therapy. It would be implemented in the latter stages of heart failure, and it most likely should be prescribed by a specialist who at least has some good experience with this particular drug in these specific types of patients. So that was kind of an introduction to digitalis. We will return to digitalis in a few other lectures, specifically in atrial fibrillation, as well as heart failure in the context of other comorbid conditions, usually associated with arrhythmias. The other thing that I wanted to kind of show you is that this is kind of a nice summary diagram, basically kind of describing different types of acute decompensation heart failures with comorbid type conditions. So here's your acute decompensation heart failure with your typical presentation, okay, and then the management strategies that would be sufficient. Here's your acute decompensation that has pulmonary edema. So here there's the congestive heart failure. Here's your acute decompensation in very low output situations. Think of maybe a gunshot wound where there's been a dramatic loss of blood. That can look like acute decompensation heart failure, especially when you think of end organ dysfunction. So dramatic loss of perfusion to several major organs. And kind of along that line of acute decompensation with cardiogenic shock. So here we're now looking at hypotension, low cardiac output, and end organ failure. And so here would be something like renal failure, extreme distress, pulmonary congestion, and so forth. And so these would be kind of the treatment strategies and kind of the frontline therapies that would be associated with each each example. And so that's the end of heart failure. We've talked about the pathophysiology, we've talked about the drug classes, and we've introduced in this last lecture series just some of the different types or subtypes of heart failure that exists. But more or less this lecture was systolic heart failure, and if you have any questions, please email or contact me, and we look forward to seeing you at the session. Thank you.